Hi everyone, I want to talk about sepsis, and I've tagged this as sepsis 1 because there is sepsis 2 where I'll be able to talk about prevention, treatment, and prognosis. But for now, we need to know the details about sepsis, how it is caused, the clinical signs and symptoms. Sepsis is a life-threatening medical condition whereby the body's response to infection has led to multiple organ failure and possible death if not tackled immediately and appropriately with correct antibiotics, fluid resuscitation, and vasopressor, as the case may be. Sepsis kills hundreds or thousands of people every day. It's a worldwide problem, so it's not local to your jurisdiction or to your hospital or to your environment, but was in poorer countries or developing nations. Sepsis could cause more death than any other disease ever diagnosed. Comorbidities are strong predisposing factors. Decreased immunity and neutropenia are also known to be aggravating factors. Definitions and epidemiology, like I've just said earlier, is worldwide. There is an increase in rate of sepsis due to increased age, and that is individuals greater than 65 years old. It's also common among immunosuppressed individuals and situations where there will be multiple drug resistance infections. Sepsis is worst among African American males and highest in winter time. In those days, we were told or we've been taught that sepsis will go through about 4 stages. Okay, that is systemic inflammatory response syndrome, then sepsis, which will be the combination of systemic inflammatory response syndrome with infection, then severe sepsis, that will be sepsis with decreased blood pressure or hypotension, and lastly, septic shock with signs of organ failure. However, things are changing. Okay, let's go. Now, we can talk about infection as disease causing agents invading tissues with release of toxins and host reactions with or without clinical symptoms. So, in other words, the fact that somebody has harbored causative agents doesn't really mean the individual will come down with clinical symptoms if the immunity is strong. Sometimes they come down with clinical symptoms. And bacteremia is a situation where there's presence of bacteria in the blood. Mostly no symptoms because immunity will take care of that. Septicemia, on the other hand, is a situation when there is presence of bacteria in the blood, that is bacteremia, and toxins from bacteria that's coming from other parts of the body and now causing a systemic disease or sepsis. Sepsis, like I've just defined, and I will not mind redefining it again to be a life-threatening medical condition whereby the body's response to infection has led to multiple organ failure and possible death if not tackled immediately and appropriately. What are the stages now? I've alluded to the stages that we're used to, like things are changing. Before, we'll start with systemic inflammatory response syndrome. It is no longer included. And why that? Because it's not always caused by infection. Now we have early sepsis. That is, once there is infection and bacteremia, then the chances of having sepsis is very high. It can be prevented at this stage. Prevention is always cheaper, right? If the diagnosis is made at this early stage of bacteremia, an infection and it is appropriately treated, like in emergency room or intensive care units or even the patient is on the wall. So we might not get into the next stage that might be scary. Then, if that stage is passed and we move to the next, which is sepsis, then there's likely going to be life-threatening organ dysfunction that will be caused by abnormal host response to that infection. Before, we were told about severe sepsis. This is no longer used. And why that? Because tissue hypoperfusion or organ dysfunction and systemic inflammatory response syndrome are all included in septic shock. Now the septic shock. This would be either vasodilatory or distributive shock. This is a stage of sepsis that involves circulatory, cellular, and metabolic abnormalities. It has a greater risk of mortality than sepsis alone. Remember, this is septic shock. When in shock, there will be severe hypotension, confusion, decreased level of consciousness, and go to coma and death. Adequate fluid resuscitation will not be enough here. A role will not suffice. Yes, will not be enough. Ask me, what else then? Then vasopressors will be required. And why that? To keep the mean arterial pressure above 65 millimeters of mercury. That is when all organs will be well perfused. Mean arterial pressure, MAP, must be 65 or above, must not be below. And we need vasopressors to do that. Okay, multiple organs dysfunction syndrome. In this case, many organs will be failing. There will be need for intervention to maintain homeostasis. It can be primary. In that case, the organ that has failed is as a result of direct injury to that very organ. For example, rhabdomyolysis could lead to renal failure. But it could be secondary. And in that wise, the failing is as a result of body response to a disease state from another organ. For example, heart failure leading to hepatic or renal failure. What are the possible risk factors? 1. Genetics. Defects of antibody production or lack of T cells could predispose an individual to sepsis. Previous hospitalization, particularly people that have been treated with antibiotics for a long period of time, will have their immunity altered and increasing the chances of coming down with sepsis. Community-acquired pneumonia, you could check out my presentation on community-acquired pneumonia, where I have categorically stated that people elderly with community-acquired pneumonia will likely come down with sepsis and possibly with septicemic shock. Cancers, and of course the treatment of the same, like chemotherapy or radiotherapy, will all increase the chances of having sepsis. Diabetes mellitus will decrease immunity. And of course, it goes without saying that when immunity is down, then the chances of infection will increase. Obesity, with all due respect, as far as all my friends with increased body mass index are concerned, they may likely come down with diabetes mellitus, and they will likely have increased susceptibility to infections and later sepsis. Still on risk factors: immunosuppression, chemotherapy, neoplasm, renal failure, acquired immune deficiency syndrome, hepatic failure, splenism, disease modifying anti-rheumatic drugs, diabetes mellitus, transplant patients, HIV, and so on, will all suppress immunity, even corticosteroids. And once immunity is down, the chances of coming down with infection and sepsis is higher. Advanced age, greater than 65 years, they suffer more compared to younger age group like 15, 20, 30, thereabout. They require more skilled intervention because of the age. Okay, they come down with more severe forms of sepsis, and mortality is higher and early into the disease. Can you guess why? Is anybody guessing? Can you tell me? Okay, let me provide my answer. Because of the age. You know, the last stage of this trouble is multi-organ dysfunction syndrome, where many organs will fail. At old age, the organs are already undergoing, regression. The organs are old already. The older you are, that is how old the organs are, right? So you're subjecting that same organ to situation where they are in trouble. They are weak. They compared to somebody at 20, at 30, or 40. You understand what I'm talking about? So that is the reason why they will suffer more, even they are exposed to the same content of the agent, the toxin, and everything, but because the organs are already becoming weak and weak as they grow older, degeneration, right? Okay, let's move to another one. Bacteremia. Not all positive blood culture patients who develop sepsis. Okay, but up to 95% of them will. Intensive care unit admission. Nosocomial infection is very common among ICU patients, and about 50% of them will have that and come down with sepsis. What are the clinical features, or what we call signs and symptoms? Fever, but let me emphasize a point here. It's not everybody, particularly elderly, that will have very high temperature or extremely cold temperature. So you'll be talking about anything at 8.3 or 0.5, depending on your jurisdiction. So many centers will choose a particular temperature. Some will choose 39 degrees Celsius, and some are using degree Fahrenheit. Okay, it's not all elderly that will show that. Okay, or temperature lower than 36 degrees Celsius as cold. Not everybody will show that. So when you are dealing with elderly people, be careful to make the judgment based on the value of the temperature. Okay, chills, rigors, tachypnea, tachycardia, dyspnea, decreased blood pressure. DIC is a big issue. I'm not going to just keep this. In fact, I'm going to make a separate video on DIC very soon. It's going to come out between now and the next 5 or 6 days, because this is a serious issue. Sepsis, if it's not tackled on time, will lead to disseminated intravascular coagulopathy. We will be dealing with thrombosis, that is clotting. We'll be dealing with hemorrhage. So the individual could come down with stroke, hemorrhagic stroke, or ischemic stroke, or myocardial infarction, and massive bleeding. Wow, serious. So bleeding, DVT, stroke, myocardial infarction will all likely follow DIC, disseminated intravascular coagulopathy. Mean arterial pressure less than 65 millimeters of mercury, and that will give us a clue that the tissues will be less perfused, because mean arterial pressure is expected to be greater than 65. I think the normal range is between that 65 and 100, thereabout. Absent bowel sounds, ileus, is possible. Then aspiration is possible, so pneumonia is possible with sepsis, and pneumonia could cause sepsis. You understand what I was talking about here? Check my video on aspiration pneumonia. When there's paralysis of the intestinal muscles, the gastrointestinal peristalsis is slowed down. There's too high likelihood of aspiration of the gastric content with the flora, in them. Still on clinical features, when the BP is down, there will be dizziness, cyanosis from inability of good perfusion or respiratory problem on its own, decreased capillary refill because of hypotension, you understand what I mean, and mottling, confusion, affecting the central nervous system with lightheadedness, oliguria when the kidney is suffering, or complete anuria. That is, you don't have any urine being produced. Oliguria is decreased quantity, right? Coma. And if care is not taken, massive resuscitation with vasopressors, we might be dealing with death. What are the possible sources of this problem? Urinary tract problem, urinary tract infection. Remember, I've just said that the kidney might suffer here, renal failure, giving us oliguria, anuria, blood urea nitrogen rising, creatinine rising, uremia, and everything. Then, someone is having frequency congestive nodular dysuria, that is irritating symptoms of urinary tract infection. So urinary tract infection could be the source here. And there's possibility that this problem is here because once upon a time, this affected patient with sepsis right now had upper respiratory tract problem with pharyngeal inflammation and exudate, swelling, and lymphadenopathy. And could this be secondary to lower respiratory tract infection with productive cough and pleuritic chest pain? And of course, on percussion and auscultation, I'm going to pick telltale signs of consolidation. How about gastrointestinal disorders? Problem there, central nervous system meningitis, and catheters that are there, central lines, even bladder catheterization for a long period of time, wound and burns, exposed skin, the tegument protection is lost. How about skin infection that is not properly treated and gets into the blood? I've talked about bacteremia, sepsemia, then sepsis, and sepsis shock, the multiple organ dysfunction syndrome. Then about bone, problem in the bone, infection in the bone, genital tract, urethritis, vaginitis, all sorts of problems in the reproductive tract down there, and peritoneal dialysis that's contaminated. I have a problem with the joints, arthritis, infection of any sort, and just multiple sources. How do we make diagnosis? Diagnosis is made clinically most of the time, and empirical antibiotics with aggressive resuscitation must start immediately. X-ray is less useful except if you are suspecting pneumonia. Okay, I also go through a long list of possible investigations, but you don't need to go through all this before you commence empirical antibiotics, please. Let me reiterate that. There's no need of long investigations before you commence your empirical antibiotics. Because this laboratory investigation may not be positive, yet the affected patient is in shock. and a septicemic shock. Still on diagnosis, you can get throat swab for aerobic culture. Get sputum, if the individual is having cough and sputum, get a sputum for culture. If this is winter time with flu, rapid influenza testing is possible. Urinary antigen testing for Legionella and pneumococcus could be done if you are suspecting that. Bronchoalveolar lavage for microscopic culture and sensitivity. Urine microscopic culture and sensitivity if you pick pus or you are suspecting urinary tract infection in individual with frequency congestive nocturia and dysuria, signs of an irritative bladder, right? And blood culture of the tip of the catheter if the individual is on any catheter, culture of the pleural fluid if you have picked pleural effusion, or even culture of the pericardial fluid when pericardocentesis has been done and you get the sample. Wound swab in case of burns or wound for culture and gram staining. If there's burns with blister, you can tap the blister and get the fluid, or take the pus if there's pus and then culture that. If CNS is involved, meningitis or encephalitis, do lumbar puncture, but rule out mass lesions or increased intracranial pressure before you put your needle down there. Do your lumbar puncture, get CSF. CSF could be cultured and also for gram staining. Stool, if you are suspecting gastrointestinal problem, and particularly if you are suspecting Clostridioides difficile, formerly known as Clostridium difficile, is now Clostridioides difficile. So you use stool MCS for other infections, but if it is pseudomembranous colitis or Clostridioides difficile, formerly known as Clostridium difficile, just go for the toxin. Okay. You can have peritoneal dialysis fluid culture if you are suspecting that could be the cause. And if this is a woman, you can have a vaginal swab or endocervical swab, microscopic culture and sensitivity, urine gram staining, urine microscopic culture and sensitivity, bone cultures with the help of a radiologist. Okay? Autocentesis, if this is joint issue, and with that you can have cell counts, gram staining, and the aspirate for culture and sensitivity. Yes, you've done the culture. Now the lab will be out. What are you going to do? Check the lab, go through it. Okay, white blood cell count, check. Greater than 12,000, yes. Or less than 4,000, yes. We're in for trouble. If the white blood cell count is within the normal range, that is 4 to 11,000, but with more immature forms, then we're in for trouble, which means there's pressure on the bone marrow to send more fighters to the circulatory system. How about hyperglycemia? I'm not talking about hyperglycemia in an elderly man who has been diagnosed with diabetes mellitus and is not taking his medication. No. Hyperglycemia when your glucometer is reading 7.7 millimoles per liter or greater in someone who has never been diagnosed with diabetes mellitus and who has never had the signs and symptoms of diabetes mellitus. Because it's not everybody who has not been diagnosed with diabetes mellitus that is actually free. because many people will not present to doctors on time anyway. So this person has no sign, no symptoms of diabetes mellitus before, or you have even checked the glucose, before admission or immediately when you're admitted. Now, when you are dealing with sepsis and you check the glucose is high. Increased C-reactive protein, and of course, increased creatinine. Still, on laboratory reports, disseminated intravascular coagulopathy should be closely watched. I mean the features on the laboratory report. I will go and check my INR. Check the INR. Check the APTT. Some will not call it INR, will call it PT. Some will just say, okay, other liver function test. Check them. Are they within the normal range? Okay. Platelets. Because let me go back to that INR and APTT. When INR is high, you are turning towards bleeding. When it's low, it's about clotting. When APTT is high, then you are turning towards bleeding. When it's low, you are turning towards clotting. You are going to find both, depending on where the DSA is sealed into and when the DSA occur. Okay? Platelets less than 100,000 will call for concern that we may be dealing with bleeding very soon. Okay? And increased bilirubin will show that it's either if it is conjugated, then we're dealing with liver problem. But it might be as a result of hemolysis already. So that will be unconjugated. And decreased adrenal function will reveal sodium that will be low, hyponatremia. It's a different thing when we're talking of syndrome of inappropriate antidiuretic hormone triggered by ectopic ADH production, either by lung cancer or something else. But when our adrenal gland is failing, we know what that means, right? A Dysonian crisis. And of course, I'm going to be dealing with increased potassium here. So when we have that, we know we are dealing with organ failure. Hyperlactate. Anything greater than 2 millimole per liter of serum lactate is not good. If the lactate is greater than 2 millimole per liter, but less than 4 millimoles per liter, then we are dealing with hypoperfusion. Get me clearly, okay? Serum lactate greater than 4 millimoles per liter is pointing to septic shock. But don't quote me that with that it is septic shock, because it is not diagnostic. Now, finally on this, increased plasma procalcitonin is not good. The value that we will expect is anything less than 0.15 nanogram per ml. If the value is low, then the risk of sepsis is also low. If we check our laboratory report and procalcitonin value is high, the likelihood of having sepsis or septic shock is also high. Decreasing value in an individual diagnosed with sepsis being treated with antibiotics means that we are winning. So decreasing value when you take serial procalcitonin after being placed on antibiotics is a good report, meaning we are having good response to treatment. And the higher the value of procalcitonin, the worse the prognosis. So with that, I'm going to end this, and the next presentation will be on prevention, treatment, and prognosis of sepsis. Thanks for listening. Kindly subscribe to my channel so you can get these presentations immediately they're published. Thank you, and I appreciate that.